Dr. Xu, time's up.
Yeah. Okay, thank you. This is Dr. Su from National Taiwan University Hospital. It is my great honor to host this section with Dr. Smongprong from Thailand. There will be 6 speakers talking about the infective endocarditis in the year 2020. We go to the next. As we know, the infective endocarditis is an insidious and potential disastrous infectious disease in cardiovascular system involving defective cardiac valve, intracardiac structural anomaly, and the aortic peripheral artery disease, with continued progress in cardiac valve reconstruction, artificial valve replacement, normal implanted intracardiac device, and the surviving complex congenital heart disease. The clinical pattern, manifestation, and the causative pathogen of IE are changing rapidly. In this webinar, we would explore in depth clinical manifestation, pathogens, and the contemporary therapeutic approach in different kinds of cardiac disease, including the rheumatic valvular IE, non-rheumatic valvular IE, prosthetic valve IE, IE in CIED, and also IE in adult congenital heart survival. This is Dr. Su from Taiwan. And Dr. Smongprong from Thailand will co-chair this section. There will be 6, the disclaimer. The content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The view and opinion expressed in this webinar are those of the faculty member and do not necessarily represent those of the APSC. The live streaming content of this webinar will be made available via the APSC Cloud, APSC Facebook, and the YouTube page. Let's go started. And the first 3 talks will be chaired by me, and the last 3 talks will be chaired by Professor Smongprong. Let me introduce the first speaker. The first speaker is Ariana Podira from Philippines. Today, she is going to give us a talk about the DUCE or modified DUCE criterion in the diagnosis of IE in the 2020. Dr. Podira, please.
Good afternoon. Thank you for inviting me here. Let me share my slides. Okay. All right. Okay. Infective endocarditis commonly affects the valve and chordae tendineae, the prosthetic valves, implanted cardiac devices, and the diagnosis is based on modified DUCE criteria. We all know that transthoracic echo is the first-line modality, and TEE has a superior temporal and spatial resolution and is usually used in the evaluation of IE. So the diagnosis of IE remains challenging and includes identification of infective pathogen and detection of cardiac lesions and non-cardiac localization of the disease. Echo remains diagnostically imperfect in cases of prosthetic valves and a cardiac implantable electronic device infection. And in recent years, other imaging modalities such as CT, MRI, nuclear imaging have experienced significant technical improvements, and the application to the detection of cardiac and extracardiac IE-related lesions seems to be a strategy. Now the use of CT is increasing now in the setting of IE. Let me show you the modified DUCE criteria in 2020 for the diagnosis of endocarditis. So as you can see here, as part of the major criteria, aside from blood culture positive for IE, you can see here the echo as part of the imaging. And then you can see here, we identify or diagnose a definite infective endocarditis if it meets the following requirements: 2 major criteria, or 1 major and 3 minor criteria, or 5 minor criteria. And for the diagnosis of possible infective endocarditis, it should meet 1 major and 1 minor criterion and 3 minor criteria. As you can see here, in the echo, it's defined as an oscillating intracardiac mass on valve or supporting structures within the path of regurgitation jets, if there's abscess or new partial dehiscence of prosthetic valve. Now, let me show you the modified Duke criteria. So in the 2023 Duke criteria for IE, these are the following changes. So I just want to highlight the imaging part. So they added the cardiac CT and the nuclear scan as part of the imaging and a major clinical criteria. To emphasize more of this imaging, aside from the echo, the part of the major criteria shows echo and or cardiac CT showing vegetation, valvular leaflet perforation, valvular leaflet aneurysm, abscess, pseudoaneurysm, or intracardiac fistula. And if there's a significant new valvular regurgitation and echo as compared to the previous imaging, or if there's a worsening of a pre-existing regurgitation. And if there's new partial dehiscence as previously noted in 2022 criteria. Now, in the nuclear imaging, in the PET-CT imaging, if there is abnormal metabolic activity involving a native or prosthetic valve, an ascending aortic graft with concomitant evidence of valve involvement, or if there is intracardiac device leads or other prosthetic material. Let me show you this table. It's quite busy, but it shows you the pros and cons of each imaging technique. So echo is a good diagnostic ability, readily available in all hospitals and diagnostic centers. It has an acceptable diagnostic ability also in a prosthetic valve, and it can also show a valvular function assessment and the prediction of the embolic risk, and very useful for follow-up because of this accessibility. Part of the cons would be the limitation in the evaluating of anterior structures such as the RBOT tract for the right-sided IE, and in the presence of any perivalvular complications, especially in prosthetic valves. And it was also some limitations if you're thinking of a packet infections for patients with ICD. Cardiac CT, on the other hand, has a good ability to detect perivalvular complications in both native and prosthetic valve, and it can show abscesses and pseudoaneurysm. It also has acceptable diagnostic ability for detecting vegetations as well, leaflet thickening and perforation and fistula. And you can also assess for the coronary artery perioperative assessment. One of the cons would be limitation in small vegetations. And of course, there's a risk for radiation exposure. On the other hand, the spec has a high specificity for infection, but of course, it is quite expensive, and not readily available in all hospitals. PET and CT also has a high sensitivity in prosthetic valve. It can show hypermetabolism anatomic lesions, such as in cases of vegetations, leaflet thickening and preparations, and fistula. It can also show definitions for any extensions of, better definition of the extensions of infections, especially if the patient has implantable cardiac devices. But it has a low sensitivity and in a native valve endocarditis, and very limited sensitivity and small vegetations. And of course, it's quite expensive as compared to the usual echo. But as you can see here, multimodality imaging plays a very pivotal role in the evaluation and management of IE, where there is a high morbidity and mortality. Now let's go on specifically in each lesions. For one scenario, for the left-sided IE, echo is the first-line imaging modality, and the main echocardiographic criteria for IE as follows: vegetations, perivalvular complications, and perforation or aneurysm. Echo, as I mentioned a while ago, is very useful in predicting embolic events. And in 2015 ESC guidelines, it recommends a surgical therapy in the cases of large vegetations because of the increased embolic episodes. Now, TEE allows a better evaluation in several situations in which TTE has a limited sensitivity, such as prosthetic valve and small vegetations, and in the presence of perivalvular abscess. And if the window is also not that good in a transthoracic, then TEE is a second line modality. So that's just in the case of this 78-year-old patient was a fever and a blood culture positives for Streptococcus agalactiae. And then in echo, it found several vegetations on the mitral valve. So in further investigation in a transesophageal echo using a 3D, so you can see here there are vegetations on the mitral valve. It's pretty large. It's about 7 to 20 millimeters, and it's causing a significant mitral obstruction. They also made use of other modalities here. As you can see here, it can show a perivalvular abscess, and then causing a compression also in the coronary sinus in the CT. And this patient, I believe, underwent operation to take off the vegetation. This is a proposed diagnosis algorithm for any suspected native valve infective endocarditis. So echo must be performed in all patients suspected with IE as a first imaging test. So both echo modalities, the TTE and the TEE, should be performed in nearly all cases to evaluate anatomic involvement and hemodynamic consequences. When TTE, transthoracic echo, is negative and it's still you are highly suspicious of an IE, then you can do a TEE to rule out the diagnosis because of its higher sensitivity to detect vegetations. It's about a 90 to 100% for TEE versus only for 40 to 63% for transthoracic echo. So beyond the diagnosis of IE, TE should be performed for better assessment, not only for detection of the valve involvement, but also the perivalvular complications. TE has a higher sensitivity than TTE to detect abscesses. So its sensitivity is 87% and specificity of 95%. Now, if both the TTE and TE are negative or inconclusive, especially when performed early in the clinical course, it should be repeated within 1 week. If it's still suspecting of an IE, if the patient is not improving and the team is still suspecting IE, then you can repeat the echo. Cardiac CT might be used in the setting of a suspected paravalvular infection, paravalvular infection extension, when the anatomy cannot be clearly delineated by echo because of this suboptimal acoustic windows, of if there are any artifacts, for example, like severe calcifications. So in addition, cardiac CT will also allow us to get the preoperative risk stratification, accurately assessing the IE-related perivalvular lesions for a better procedure planning, and then also allows the evaluation of coronary artery disease. Now, if the PET scan is available, it can be also used as an alternative or complementary technique to cardiac CT. Although there is no consistent scientific evidence, the addition of metabolic activity information could increase the diagnostic accuracy. Okay, so this is only for the native infective endocarditis. Now, what about the right-sided IE lesion? So the right-sided heart involvement is common in intravenous drug users, easy to detect with the TTE because of the anterior location of this valve, and they're usually large vegetations. But also the limitation of doing echo in these cases, it requires multiple views to image all 3 leaflets of the tricuspid valve. A 3D TTE, if it's available, can help identify the specific leaflet or leaflets involved. So in this case, TE can supplement a suboptimal TTE, and it can also, the right-sided IE can also occur with extension of the aortic root. Pulmonic valve, on the other hand, the involvement of pulmonic valve in endocarditis is very rare and possibly underreported due to TTE and even TE imaging challenges. But just to show you how it should look in the TEE, this is an example of a pulmonic valve vegetation in a TEE. All right, so multimodality imaging, so the usage of cardiac CT and nuclear techniques aside from echo. So PET scan is useful in patients. CT and nuclear imaging is useful in patients with the evidence of pocket infection, but have minor roles in native valve echo, but it also should be considered when there is an absolute contraindication to TEE. For example, if the patient is hemodynamically unstable, well, you can do a CT or a nuclear imaging where it's less invasive. CT is an excellent tool for evaluating pseudoaneurysms, abscesses, and a fistula. And the PET-CT is useful in patients with evidence of pocket infection, fluctuans, wound dehiscence, erosions, tenderness, or any purulent discharge or drainage with a negative microbiological or echocardiographic examination, or if the echo has a suboptimal views, and in patients with positive blood cultures but negative echo examination, especially if there are any limitations in the acquisition of the images. So vegetations in cardiac CT appear as low to intermediate attenuation lesions with the variable sizes and the focal thickening along the valve, endocardium, or prostheses. So the sensitivity of TE for detecting vegetation is about 85 to 100%. And it was reported by Habs et al. That the usage of CT can increase the sensitivity of vegetation detection, but more on in the prosthetic valve endocarditis, from 63% of echo to 100%. So the presence of prosthetic valves or any calcifications that we see in echo can really pose a diagnostic challenge for detecting the vegetation at the usual TE or TTE. So that's why the usage of CT can help us and can increase the sensitivity of detecting vegetations. Another study by Footner et al. Reported 96% sensitivity and 97% specificity for detecting vegetations with 4D CT compared with surgical findings in 29 patients with IE affecting a variety of cardiac valves. So in another retrospective review of patients, although these studies have only few patients, but it demonstrated higher detection rate for vegetations than CT, but on TE versus a CT for small vegetations. So if it's less than 10 millimeters, they're usually underdiagnosed at CT, and can be, in this case, TE can be a more appropriate, it will be a more appropriate diagnostic modality as compared to CT. Okay, just to show you again, this is a comparison, a table of comparison of findings from echo and a CT. Like in vegetation in echo usually is an oscillating or non-oscillating intracardiac echogenicity that is attached to cardiac valves. Can also involve the perivalvular parts and the chambers, and if there's an intracardiac device. But in CT, it is a low to intermediate attenuation with a variable sizes. For the perivalvular extension, usually in echo, these are non-homogeneous perivalvular thickening with high echogenicity or echo for appearance. Might be an artifact, can be mistaken as an artifact. Whereas in cardiac CT, it appears as a low attenuation area with peripheral enhancing rim. Pseudoaneurysm, you can also detect that if the acquisition is good in echo, but is clearly seen in CT. as compare also with the fistula. Okay, it's much better seen in CT as compared to echo. In cases where there's a prosthesis, in echo, you can appreciate a paravalvular regurgitant flow on the echo Doppler, but you may or may not see a rocking motion of the prosthesis. Whereas in cardiac CT, you can appreciate the malalignment of prosthesis with tissue defect between the annulus and the prosthesis. And you can see the rocking motion much better as compared to echo. So other leaflet abnormalities that we can appreciate in patients with IE are leaflet perforation and aneurysm. So in leaflet perforation, the leaflet tissue defect is seen in echo with evidence of flow through the defect on color Doppler images. And it can also observe in CT in two different views. Aneurysm, you can also see that as a distorted leaflet with saccular outpouching and loss of its homogeneous curvature. And also in CT, it is seen as a saccular outpouching as well. Just to highlight again, that the CT, cardiac CT, has a complementary role to echo in the workup of IE and does not replace echo. However, cardiac CT is valuable in patients who have contraindications to TE and in patients who are strongly suspected of having IE, but with suboptimal views in echo, probably because of calcifications or prosthetic valves, or simply the patient has a poor echo window. Coronary CT is also appropriate for assessment of coronary artery disease before a non-cardiac surgery in patients with intermediate pretest probability, and it has high diagnostic accuracy and excluding clinically significant coronary artery stenosis in patients undergoing valve surgery. Therefore, coronary CT angiography is a practical diagnostic step to assess a perivalvular extension, coronary arterial anatomy, and a coronary artery disease simultaneously prior to cardiac surgery for IE. Okay, just to show you again, another image from a right-sided IE lesion. So this is complicated up by a pulmonary embolism. As you can see here, they make use of a TE as well as a cardiac CT. This is a 29-year-old man. Is an intravenous drug abuser and was admitted for a fever and a blood culture positive. So in the TE, you can see a very large lesion. And in the case of a stop or use tricuspid native valve involvement, endocarditis, it is promptly diagnosed in a TTE, and then this patient underwent a CT, and as you can see, there also pulmonary embolism. So this case illustrates the role of multimodality imaging evaluation in patients with right-sided NVE, in whom CT was useful for an adequate assessment of septic pulmonary embolism lesions as well. All right, so now let's go to the nuclear imaging techniques. So in the usage of the PET and CT imaging, it's now part of the major criteria. If there's any abnormal metabolic involvement in a native or prosthetic valve, an ascending aortic valve, and with concomitant evidence of valve involvement, and if there's any intracardiac device leads or other prosthetic material. So this is now part of the revised or the modified criteria of 2023. To show you what does it look like, this is a case of a cardiac implantable electronic device related infective endocarditis. It is a 66-year-old man with an ICD generator placed on the left side. And as you can see here, there are pocket lesions and as evident in the PET CT. Okay, so the usage of this multimodality imaging in this case in a high-risk patient with a local catheter implantable device lesion is very significant as a part of the therapeutic decision, because as you can see in the echo, it's not quite evident of the lesion, but in the PET CT, it's very evident where, as you can see, the other involvement of other lesions. Now let's go to the role of cardiac MRI. Though it's not a part of the criteria, theoretically it has a superior 3D assessment of cardiac structures and morphology as compared to echo or CT. It can also show myocardial involvement in IE and identify vegetations through tissue characterization. So if you have any dilemma whether it is a thrombus, a calcification, or a mass, cardiac MRI can also give you a good image of the mass. So, however, it can also show paravalvular extension with the usage of delayed contrast enhancement. So the role of the CMR in the diagnosis of IE still requires further clarification. So, but we don't know, but maybe in the future it can be it will not be part of the criteria for IE. Okay, to show you the one image, okay, this is a lesion in the mitral valve, and then in the echoes you can see a mass there in the mitral valve, but in the cardiac MRI you can clearly see the lesion attached to the mitral leaflet. All right, so the advantages and limitations of each modality aside from echo is seen is being flashed here in this table, the PET scan and the MRI. So MRI is still not part of the criteria, but who knows, maybe in the next few years it will be a part of the Duke criteria again. Not again, a part of the Duke criteria. So the question would be which technique for which patient. So transthoracic echo should be performed in all patients with suspected right-sided or left-sided heart endocarditis. And if there's dilemma for the TTE, then you can do a TEE. Transthoracic echo is readily available, so it can be used as a follow-up modality for all your patients. We use the CT, the PET, and the coronary CT if we're suspecting any if you're still suspecting IE in spite of a negative culture or a positive culture with a negative echo, or if you cannot identify or the lesion is not well delineated in a transthoracic echo. Cardiac MRI, if you still have diagnostic dilemma and if considering extension of infection, then you can make use of the cardiac MRI. But you should be minded that the cardiac MRI is still not part of the modified Duke criteria for IE. So for my conclusion, the decision to use multimodality imaging should ideally be made in reference centers complemented by the use of the endocarditis team. So it should be patients with IE should be referred to a team that will decide which modality aside from echo to make use. Of course, we are also dealing with the economy of using a multimodality here. So the determination of the multimodality prognostic value is still should also still be considered. The cost efficiency of using these modalities and the assessment of the feasibility of using these modalities in different countries with different access to imaging techniques, because not all the hospitals will have all the said modalities. Some will only have CTA and echo, some will only have a cardiac MRI. So we should decide what is more economical and practical for our patient. And ideally, if you're considering IE, the decision to use which multimodality should be discussed with the whole endocarditis team. So that would be my last slide. Thank you very much.
Thanks, Dr. Cordera, for your excellent review about several imaging techniques for the diagnosis of IE. Because of the time limits, we could only allow one short question from the audience or the panelists. Is there any question from the audience? Okay, if there is no question, we should proceed to the next topic. The next speaker is Dr. Muhammad Abdullah from Pakistan. Today, he is going to give us a talk about the IE in rheumatic valvular disease. Dr. Mohammed, please.
Thank you. Let me share my slides. Bismillah ar-Rahman ar-Rahim. I'm thankful to APSC for giving me the talk on infective endocarditis and rheumatic valvular disease. So I will cover some of the introductions and association of infective endocarditis and rheumatic valvular disease, and talk something about the management like investigation, prevention, and treatment. And at the end, I will discuss the challenges being faced by a patient having rheumatic valvular disease and infective endocarditis, and the challenges being faced by the consultant diagnosing infective endocarditis and rheumatic valvular disease. So we know that infective endocarditis is a severe infection of the heart's inner linings or valves, and rheumatic valvular disease results from rheumatic fever leading to damaged heart valves. So the valves involved in both conditions, although the diagnostic modalities are different, the criteria are different, but the main involvement in the heart valves. And the annual incidence, we know it's 3 to 10 in 100,000, and mortality is about 30% at 30 days, a quite high mortality of infective endocarditis and valvular disease. Now, if we talk about the infective endocarditis, generally there is increased mean patient age, a higher proportion of prosthetic valves and other cardiac devices, and astonishingly, almost 50% of those infective endocarditis present with cardiac surgery. And the healthcare association is quietly increased in new eras, which is 25 to 30%. Now, there is change in causative organisms. Staph is increasing about 26% generally in widened groups, followed by streptococci and enterococci. So if we talk about rheumatic heart disease, usually there is not such critical and clinical guidelines, but there is a study, a remedy a registry, which included almost 3,000 participants, and they were astonished to see that 2.4% have already infected endocarditis. And when they follow the people for about 2 years, they see that it 0.57% increase, which is 3.65 per 1,000 patient per year, which is quite huge amount for those who have rheumatic heart disease. And now if you compare the patient who have already rheumatic valve disease as compared to those who don't have rheumatic valve disease, people present with infective endocarditis are at younger age. Women are more commonly involved, about 2/3, and 30% of children. In low and middle socioeconomic countries, such like our country, we have very uh, 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 there's much health system barriers which prevent us from prevention, early diagnosis, and advanced care. So when you look to global access to surgery for rheumatic heart disease, and rheumatic heart disease complication is extremely limited. In endemic areas, the most common underlying cardiac conditions for infective endocarditis, mortality and morbidity is rheumatic heart disease. And when we talk about the species in rheumatic heart disease about infective endocarditis, Streptococcus species is the common species being involved. Now, the mortality in infective endocarditis is quite high, but if we look into the mitral valve surgery and rheumatic heart disease, those who have infective endocarditis, they have high mortality, and patient having rheumatic heart disease becoming pregnant have more risk of infective endocarditis, and high income countries have low risk of infective endocarditis and rheumatic heart disease. Now, generally, when we talk about the diagnosis of infective endocarditis, we always look for predisposing factors in those status. And you look here, the rheumatic valve disease is one of the predisposing factors for infective endocarditis in established guidelines. And the other thing is prosthetic heart valves. So basically, most of the prosthetic heart valves, the reason is rheumatic valve disease or rheumatic heart disease. So the previous speaker well elaborated the Dew's criteria. I'm not going into the detail of Dew's criteria, but in minor criteria, it is included that predisposing condition, which is one of them is rheumatic valve disease, is a minor criteria in patient who develop infective endocarditis or have a risk of infective endocarditis. The clinical presentation is different in infective endocarditis, which lesions coming first. But in rheumatic valve disease, keep remember this thing, when there's new or changing murmurs or there's fewer, then always and always suspect infective endocarditis. We have to keep the threshold very low about infective endocarditis, specifically in rheumatic valvular disease. Same in valvular heart disease, rheumatic valvular disease, staph is again about 31%. In native valve disease, non-rheumatic, it is 26%. It is followed by streptococci, and E. faecalis is also involved in elderly patient. Now, there is a change in pathogens over time. If you look into that, shifts in pathogen prevalence due to changes in antibiotic use and healthcare practices. I think everywhere in the world, but in our part of the world, we are using antibiotic like anything. Like if you're using antibiotic like paracetamol, before going for paracetamol, we go for antibiotic use. So in early 20th century, streptococci was predominated. In mid to late 20th century, rise of Staph aureus is much high, and in recent trends, there will be new bugs coming in because of increased antibiotic resistance, emergence of healthcare associated infections, and much other things. Now, our colleagues describe in a very elaborative way the diagnostic tools. Same for valvular heart disease, transthoracic echo is the main modality to diagnose it, followed by transesophageal echo, which visualize vegetations and can differentiate between the well involvement in vegetations. Same blood cultures are recommended in serology is by modified Dew criteria, but challenges are there in those who have valvular heart disease because it's very difficult to distinguish infective endocarditis from non-infectious causes of valvular dysfunction in rheumatic valvular disease. This is one of the study being conducted in Australia in a very developed country, and you can see that severe rheumatic heart disease have association as well as prosthetic valves. Although the other things have no association, developing infective endocarditis in patient with valvular heart disease. And it depends because in valvular heart disease, you see there's recommendations of benzyl penicillin, and uh, most of the people they are not using benzyl penicillin. Those who are using benzyl penicillin every month, they have less chances of common infections as compared to those who are not using it. Now coming about management, so any infective endocarditis in valvular heart disease should be treated like the native valve disease, and the empirical treatment followed by pathogen-specific antibiotics and surgical intervention is recommended. This indicated by severe valve damage, heart failure, or persistent infection. If you look into the guidelines previously or the fresh guidelines being published in 2023 by the European Society of Infective Endocarditis, there's no clear-cut demarcation between valvular heart disease treatment management or non-valvular heart disease treatment regarding the antibiotic. So it is the same as the fluoxetine and for prosthetic valves, vancomycin, benzyl penicillin, and all these things that should be given. Now, this is the most important slide over here. Preventive measures are important and value when one it's usually important, but if your patient have valvular heart disease, you have to emphasize on preventive measures. And this is the good dental hygiene. Use your dental floss daily, brush teeth morning and evening, see your dentist for regular checkups, and maintain good skin hygiene, although there is no strong association between that. But there are studies which uh, give clue that skin infections are one of the skin problem is one of the causative of infective endocarditis. And be mindful of infection. As I discussed in the previous slides, that if you experiencing fever for no obvious reason, contact your doctor and discuss appropriate action based on your risk of endocarditis, specifically in valvular heart disease. And do not self-prescribe antibiotics. This is very important. Now, I will talk something which is challenges in management of infective endocarditis and rheumatic valvular disease. So, diagnostic challenges, therapeutic challenges, management challenges, and patient-specific factors. So, we will discuss briefly one by one. So, in diagnostic, one is the atypical presentations. Rheumatic valvular disease patients often have chronic valve abnormalities, making it harder to distinguish new infective endocarditis-related changes from existing damage. Same as for symptoms of infective endocarditis can be masked or attributed to chronic heart disease. That's why I discussed that new or change in murmur and fever should be suspected for infective endocarditis. Now, whenever we do the TTE or TE for rheumatic heart disease to detect the vegetations, they have less sensitive, the TET, and detecting vegetation on already damaged and deformed valves. Although TE is often required for better visualization, but it may not be readily available in all healthcare settings. And same as discussed previously, the CT and the FDG, they may be of some helpful in valvular heart disease, but not being studied properly. In blood cultures, there is changes of blood cultures in patients, and intermittent bacteremia can result in false negative results. Prior antibiotic use can suppress bacterial growth in cultures, leading to difficulty in pathogen identifications. So, talking about therapeutic challenges, antibiotic resistance has a huge rise in its increasing prevalence of antibiotic resistance, such as MRSA complicates treatment protocols. Prolonged antibiotic courses have been advised, which is 4 to 6 weeks, can lead to side effects and complications, specifically in older patients or those who have comorbidities. Patients with rheumatic valvular disease, they're using different drugs. So there's drug interactions and toxicity by multiple medications for heart failure or other conditions, which increase the risk of drug interactions. In long-term use of potent antibiotics can cause renal, hepatic, and other organ damage. Talking about surgical considerations, so surgical intervention poses higher risk in rheumatic valvular disease because previous surgeries, there's adhesions, fragile cardiac tissues, and post-operative complications are more common in patients with rheumatic valvular disease, as we discussed about the mitral valve. Now, management challenges is usually the complex medical history. There's history of recurrent streptococcal infections and previous hospitalizations, complicating current treatment and management plans, and follow-up and monitoring. Regular monitoring for recurrence of infections, valve functions, and heart failure can be resource intensive, specifically in lower socioeconomic countries, and adherence to long-term prophylactic antibiotic regimes to prevent recurrent infective endocarditis can be a challenging task to be done. So healthcare access and resources is also a main management challenge in such patients. Now, talking about patient-specific factors, so age and comorbidities, like older patients and those with comorbidities such as diabetes, renal diseases, or immunosuppression face higher risk during treatment. polypharmacy increases the risk of adverse drug reaction and complicates treatment regimes. Last but not the least, the socioeconomic and lifestyle factors. So socioeconomic status, living conditions, and access to clean water and hygiene affect the risk of recurrent infections and overall health outcomes. And you can see specifically in our part of the world, we are facing such difficulties in a huge amount. Education on hygiene practices and adherence to treatment protocol is crucial, but can be challenging to implement. So coming to my last slides, conclusions of rheumatic heart disease, valvular disease, infective endocarditis. So infective endocarditis and rheumatic valve disease patient presents unique challenges and considerations. Pathogen profiles have evolved over time influenced by antibiotic use and healthcare practices. Early diagnosis and tailored treatment are crucial for improved outcomes. Importantly, STEP is emerging as most prevalent causative organisms, and emergence of MDR and XDR pathogen poses a great threat to efficacy of antibiotic regime being used. Thank you.
Thank Dr. Mohammed for your comprehensive reviews of IE in rheumatic heart disease. Is there any question from the audience or the co-chairman? I think this topic is very important, especially for the developing countries. The rheumatic heart disease is had a large burden in developing countries.
I have one question from the speaker. Hi, I'm Smonporn, the co-chair of this session. Do you have any problem distinguishing the patient with previous rheumatic heart disease and have fever, whether the patient has recurrent rheumatic fever or just had the IE?
So that's always challenging. In our part, when we see our patients, most of the rheumatic fever and rheumatic heart disease are undiagnosed. When they present to you, they have already years and years with rheumatic heart disease being treated by asthma like things for that. But recurrence are there because the people are not used with the antibiotic prophylaxis which is recommended. It is painful, although it is cheaper, but it is painful, and the people there's no as such response or management improvement with these prophylaxis. So people are not going to used to with these prophylaxis. But whenever we have a patient with fever, and those who are undiagnosed or previously diagnosed with rheumatic valve disease, we always keep our threshold for infective endocarditis very low, and we send the culture for these people. We look for the criteria for both for valvular as well as for the rheumatic as well as for the infective endocarditis.
Thank you.
Any further questions from the audience?
Can I have another question? Oh, I think that there's a question from the floor, the audience.
Yeah.
The question is, for false negative result pathogen identification, almost 90% in our hospital is false negative. What is your comment and recommendation for us from Indonesia?
So false negative results about the culture is very common in every part of the world. That's why we have the other criteria, echocardiography, and now the CT imaging and the FDJ and maybe the MR in future. Same as for the minor criteria, you have to look for the minor criteria. And the false negative results have so many things to be considered, because the people are using antibiotic before coming to you, and there are some other physicians have been started. The culture should be taken on the proper way, in a proper position, in a proper gadgets. So these things can reduce the false negative results. And the other modalities should be used, and major and minor criteria both should be evaluated for the diagnosis.
Okay, thank you for your excellent answers. I think the other image modality is very important for the diagnosis of IE, especially for the patient with cultural negative. Maybe we should proceed to the third speaker. The third speaker is Dr. Zhengwei Chen from Taiwan. Today, he is going to give us a talk about the prosthetic valve, i.e. the diagnosis, pathogen, and the reintervention. Dr. Chen, please.
Okay, let me share my slide. Good afternoon, everyone. I'm Jeremy Chen from National Taiwan University Hospital. Today, I am discussing the diagnosis of pathogens and the reintervention strategy for prosthetic valve endocarditis, the PVE. This slide shows typical images of prosthetic valve endocarditis. On the left, we see a valve from a patient who received AVR with a bovine pericardium valve and developed PVE with streptococcus infection 4 years later. The top right image shows another patient who had acute aortic valve obstruction 6 months post-surgery. She underwent an emergent operation, and during surgery, we can see the vegetation on the leaflet limiting the leaflet opening. And both the blood culture and the vegetation culture report a Crohn's infection. The bottom image shows another valve with overgrowth vegetation with culture reporting enterococcus. The incidence of PVE has increased over time. Early studies reported that about 5% of all endocarditis were PVE. However, recent studies show that nearly 20% of endocarditis are now PVE. This trend can be attributed to the aging population and the rise of transcatheter interventions, especially the increasing number of TAVR procedures. The incidence of a PVE in surgical AVR is 0.5 to 1 per 100% years, with tissue valve have a higher incidence than mechanical valve. Recent data indicate that TAVR valve have a higher incidence of PVE compared to the surgical valve, range from 0.3 to 2 per 100% years. Most studies show that the PVE risk is higher in the first post-operative year. The risk factor for PVE included type of valve, comorbidity condition, and the health care exposure. The study have found that tissue valve have a highest instance of PVE, while the Rose procedure with native tissue have an even zero instance of PVE. Patient comorbidity also increased the risk of PVE. The TAVR procedure was initially applied to patients with high comorbidity, which might explain the high PVE risk in TAVR compared to SAFER. Patients with frequent healthcare contact, such as dialysis patients, have a higher incidence of PVE due to increased exposure to nosocomial infection. PVE can be classified as early or late based on the onset time after surgery. Early PVE usually occurred within 1 year post-surgery. The common pathogens are associated with the healthcare setting, including drug-resistant S. aureus and Crohn's. Other important pathogens include streptococcus, enterococcus, GMB, and Candida. The late PVE occur after 1 year post-surgery, with pathogens similar to native valve endocarditis. To be cautious, Q-tip bacteria occur, a skin flora, It can cause later presenting nosocomial PVE. In TAVR IE, enterococcus invasion are predominant due to the common use of femal acids. This table shows the pathogens of PVE based on data from large registry reports. The ICE study included patients from 2000 to 2005 in European and USA countries. The GAMES study included patients from 2009 to 2020 in a Spanish registry. The gram-positive pathogen remained the predominant cause of IE, and the streptococcus is most common in native valve infected endocarditis, and the Staphylococcus aureus is most common in PVE. This table also shows us an increase in Crohn's processive valve infection in the later study. Additionally, the TAVR IE had 1/4 of enterococcus infection is significantly higher than surgical PVE. While the GMB and the fungus are rare pathogens, they remain important in both native and processive valve endocarditis. To diagnose the PVE, the 2023 Duke IS-CVID criteria provide the most accurate diagnostic performance. The main change in this criteria is the increased emphasis on imaging tools to diagnose the infection. In addition to echocardiography, greater importance is placed on cardiac CTA and the FDG PET CT scan. Compared to the ESC guideline and the earlier Duke criteria, the 2023 Duke IS-CVID criteria provide a better sensitivity for diagnosis of PVE. This improvement potentially allows for earlier detection of possible cases, facilitating earlier intervention and preventing more challenging complications. Let's go through the 2023 Duke IS-CVID criteria. A definite IE diagnosis can be made through pathological finding or clinical criteria. The clinical criteria can be met with 2 major criteria, 1 major and 3 minor criteria, or 5 minor criteria. Among the major criteria, a positive blood culture is an important indicator for endocarditis. For difficult to culture or slow-growing pathogen, PCR and the antibody titer can be used as an alternative diagnosis tool. In addition to echocardiography, the most significant change in this criteria is the increased importance of CTA images and the PET scan as major criteria. In the minor criteria, a history of a previous IE or implanted device, such as processive valve or ICD, is considered a predisposing factor for endocarditis. This TEE echocardiography shows a large vegetation on the processive valve. The echocardiography is traditionally the first-line diagnostic tool for endocarditis. However, its sensitivity for PVE is lower due to the artifact, especially for the transthoracic echo. However, the transesophagus echo TEE has a higher sensitivity for detecting valve dysfunction and the PVE complications, including valve perforation, abscess, pseudoaneurysm, and the peripheral leak. To diagnose PVE, the TEE should always be performed and it should be repeated if initial findings are negative, but the patient is still under highly suspicious. This CTA image shows a large vegetation on a prosthetic aortic valve. The EKG-gated cardiac CTA provide high-resolution images and can offer valuable information on peripheral complications. It also provides the intracardiac anatomy, valve, and coronary artery. This information is very important for planning challenging restenotomy surgery. This PET scan image comes from a patient with a previous bento operation who developed GMB bacteremia 4 years after surgery. The TEE echocardiography could not identify vegetation on the valve, but the PET scan identified hot spots on the aortic on the prosthetic valve and the graft. The PET scan offers the highest sensitivity and specificity for diagnosis endocarditis. It can not only diagnose the PVE, but also detect graft infection, making them extremely useful for confirming or ruling out PVE in suspicious cases. However, to differentiate postoperative inflammation from true PVE within the first 3 months post-surgery can be challenging. Usually, the true invasion shows more intense and focal or multifocal heterogeneous uptake on PET scan. The PET inflammatory scan can also be used to monitor the effectiveness of medical treatment. This is a 76-year-old male patient with a history of AVR and grafting. 6 years post-surgery, his blood culture shows streptococcus. The PET scan confirmed PVE, and after completing IV antibiotic treatment, a follow-up PET scan showed a resolution of the inflammation signal around the graft. This patient was regularly followed up in the clinic, monitoring the CRP procalcitonin and the clinical sign of invasion without requiring surgical intervention. This figure illustrates the algorithm for PVE treatment. A minimum of 2 weeks of IV antibiotic is required. During this period, the need for surgical intervention should be assessed. For patients with heart failure or at high risk of PVE complication, including valve dysfunction, root abscess, pseudoaneurysm, or perforation and fistula formation, early surgery should be considered. Following the acute phase, antibiotic treatment should continue for at least 6 weeks. For some patients with high risk recurrent invasion, a lifelong antibiotic may be necessary. The principles of surgery are debridement, drainage, and reconstruction. For aortic PVE, surgical options vary depends on the extent of the invasion. The valve replacement can be performed in case with limited valve destruction. For patients with annulus abscess or destruction of the intervalvular fibrosa, root replacement and fibrous skeleton reconstruction should be considered to achieve complete debridement and reduce the risk of peripheral leak or late pseudoaneurysm formation. There is a low threshold for aortic root replacement because this procedure provides better debridement and superior long-term hemodynamic performance. Isolated mitral PVE is different, with most patients undergoing straightforward reduced mitral valve replacement. In very unusual situations where the risk of reduced surgery is extremely high or cannot reconstruction anatomy, heart transplantation could be considered after heart team meeting. The lifelong antibiotic therapy is required for non-surgical patients. The number of non-operable cases have increased over time, especially in tougher IE patients. They are usually have a high surgical risk and decided to treat with transcatheter procedure. Given the aging population and the increase in patients with a high burden of comorbidities in high-income countries, we can expect that the percentage of non-operable PVE patients with surgical indications will continue to rise. Most of these patients will eventually receive lifelong antibiotic therapy. This table summarizes 21 cases of PVE from my personal and Professor Xu's clinical experience. The red background indicated the 12 patients who undergo surgery, and the blue background indicates the 9 patients who received medical treatment only. Among our 21 cases, 5 had previous IE and experienced recurrent as PVE. Not all patients present with fever. For instance, 1 dialysis patient and 1 SOE patient present with general malaise only. All our patients had positive blood culture. Vegetation was not always detected on TEE. Some patients require PET scan to confirm the diagnosis of PVE. Most patients without obvious vegetation on the valve and use TEE use PET scan to make the diagnosis were treated with medication only. Patients presenting with acute heart failure receive urgent surgery. Then regarding the time and the pathogen. Regarding the pathogen, most PVE cases are caused by gram-positive coccus, including S. aureus, Crohn's, streptococcus, and enterococcus. Other rare pathogens, including 2 Cutibacterium acai, 1 Salmonella, 2 GMB, and 1 fungus invasion. One of our patients had a polymicrobial infection involving streptococcus and MRSA. She was died of MRSA medial stenosis surgical complication. The majority pathogen of early PVE is Crohn's, is 42%, and the late PVE is streptococcus, is 36%. Among our 12 surgery patients, the in-hospital mortality rate was 8%. The medical treatment group had all survival, except for one patient who was indicated for surgery, but whose family decided on DNR and hospice care due to old age and multiple comorbidity. To summarize our surgical outcomes, of the 12 patients, nine of them had aortic PVE. Among them, 4 underwent redo aortic valve replacement, 4 required root replacement with bento procedure, and 1 patient received intervalvular fibrosa reconstruction. All 3 mitral PVE patients underwent redo mitral valve replacement only. The in-hospital survival rate was 92%. One of these patients had a late recurrent invasion and died from sepsis 6 months post-discharge. Among the 8 patients selected for medical treatment, all patients completed 6 weeks of in-hospital IV antibiotic treatment. 4 patients were discharged without antibiotics, and the other 4 high-risk patients were discharged with lifelong antibiotics. One of these patients, a drug abuser with poor medical compliance, had a recurrent invasion and sepsis death 6 months after discharge. Take-home message. The prosthetic valve endocarditis remains a significant clinical challenge. Advanced imaging modality, including TEE and PET scan, are essential for early and accurate diagnosis. For patients with prosthetic valve or graft, fever or bacteremia should be treated with high suspicion. If TEE failed to identify vegetation, a PET scan should be promptly arranged. The combine of surgical intervention with appropriate antibiotic therapy can significantly improve long-term survival outcome. Please see the reference for the detailed information. Thank you for your attention. Welcome. Any questions?
Thanks, Professor Chen, for your excellent talk about the PVE, especially the diagnosis and the management, and also personal experience. Any question from the audience? I think that the PVE is very important. Its incidence is increasingly and rapidly growing. And it is also a burden for the cardiac surgeon. I think the management is quite different from the native valve IE. Is there any question? Professor Smoonpa?
Yes, I would like to say that I really appreciate having surgeon talking about the PVE endocarditis, because usually it's a very nasty situation, and I really admire the difficulty in you performing the operation, all of that. I have one question. Usually these patients sometimes come in with acute cerebral embolism from the vegetation. And what is your practice when you are having to operate on the open heart surgery on this patient? Will you wait because of the fear of hemorrhagic transformation during the bypass, or would you like to go in and, what is the precaution for that?
Yeah, it's a great question. Yeah, so for patient with embolic stroke after infectious endocarditis, usually we will wait a month to do the heart surgery. Yeah, and if the patient have a severe heart failure symptom due to the infectious endocarditis is more difficult situation. Yeah, so you have to struggle about doing surgery first or consider about the stroke risk. Yeah, I think Professor Xu can provide a better answer for this question.
I think the cerebral complication in endocarditis is very difficult to treat, and the incidence of a cerebral complication will up to 25%. If the patient have the intracranial, intracerebral bleeding, almost you cannot do the surgery within six weeks. So you have to wait. Otherwise, the patient will die on the table. But if the patient have small embolic stroke, you can do the surgery immediately. If the patient has large the cerebral infarction, then you have to wait for maybe 2 to 4 weeks. But the risk is still high for the surgeon. Yeah. Any further question?
I saw a question from our audience. Yeah.
Yes.
Is there any difference in outcome for bioprosthesis vs mechanical prosthesis in valve IE? Yeah, it's a great question. Yeah. Actually, there is no randomized control trial to compare this type of valve in PVE. Yeah, but from the observational study, surgeons believe bioprosthesis have a lower instance, have higher instance PVE than mechanical prosthesis. Yeah, but there is no randomized control trial. Yeah.
Yeah, I think the mechanical valve have more resistance to the bacterial invasion and also provide the adequate valve function if the bacteria can be treated medically. Yeah. Any further question? I think the Professor Spongpong were in charge of the next three speakers. Professor Spongpong, please.
Thank you very much. I would like to introduce the fourth speaker for today, Dr. Hong An Thien from Vietnam. He's talking about infective endocarditis in non-rheumatic valvular diseases, any manifestation or pathogen change. The floor is yours, Dr. Thien.
Yes, thank you very much for your introduction. And good afternoon, the chairman, the college, and the audience. So I would like to present my topic. So my topic will talk about the infective endocarditis in non-traumatic valvular disease and infestation or pathogen change. About the introduction, so as you know, that the IE is infective endocarditis is a serious infection of the heart valves, traditionally associated with the traumatic heart disease, but increasing as in non-traumatic valvular disease. And about the relevance, we know that the understanding the differences in manifestation and pathogens in IE's case relates to the non-traumatic valvular disease is crucial for diagnosis and treatment. And authorities of my topic is to examine the clinical presentation of IE in non-traumatic valvular disease and identifies any shifts in causative pathogens and discuss implication for clinical practice and patient's outcomes. About the infective endocarditis in non-traumatic valvular disease is a lot of the circumstance. For example, prosthetic advanced endocarditis, we already here topics before endocarditis in the elderly, characterized prosthetic one endocarditis, infective endocarditis affecting cardiac implantable electric device. We will hear some topic after my topic. And infective endocarditis in patient admitted to intensive care units, right-side infective endocarditis, and endocarditis in congenital disease, in rheumatic disease. We already hear today's infective endocarditis during pregnancy, infective endocarditis in immunocompromised patients, and non-bacterial thrombotic endocarditis and infective endocarditis and malignancies. So we have a lot of the circumstance demography of the IE. For example, in the picture A is the non-bacterial, B is papillaris fibro A plasma, C is infective endocarditis, D is the toxic valvulopathy, and E is the rheumatic heart disease, and F is the myosoma. So the content I talk in my topic is related on the 2023's ESC guideline for the management of endocarditis. About the endocarditis in the elderly, we know that the changing about the demographics. For example, increasing the prevalence in the elderly population, specific feature unique to this group. And the common etiological agents is the Enterococcus and Staphylococcus areas. About the contributing factor is the higher presence of intracardiac prosthetic device, for example, CIED, valvular prosthesis repair, or TAVI device. The second is increased incidence of healthcare associated IE episode. And clinical observation is a low risk of embolus episodes compared to younger populations. And about the positive impact of surgery, the study indicates that the cardiac surgery improves clinical outcome for IE patients. And surgical hesitation exists due to old age, comorbidities, and prior procedures might cause more worse to the patient with the IE. The underutilization of surgeries, for example, less frequency of carotid surgery, and increased mortalities in elderly versus younger patients. The SQUAD study shows the underuse of surgery in elderly and higher 1-year mortality without surgery. About the European Society Guidelines, bigotry for the Eros endo, they conclude that the surgeries less frequently performed in patients above 80 years, but the mortality similar to those below 80 years after surgeries. About the prediction of outcome, the functional and nutritional status are critical predictors of the outcome of elderly IE patients. So in this, we have one status for the elderly patient is the nutritional is very important. About the congenital prosthetic one endocarditis, about the incidence, it's range from the 0.3 to 1.9 per 100 patient years. And compared to surgical aortic valve replacement rate, one study noted that the lower incidence of prosthetic one endocarditis after TAVI compared to a surgical prosthesis. So with this study, maybe we can suggest use the TAVI more effective compared to the surgical. The timing and risk factor, high risk of IEs within first year, especially in the first 3 months. And recently, years show that the modest decrease in IEs incidence due to technical improvement and reduced various procedures complications. About the consistent rates across one time, there's no difference between the one size for the prognosis about the complication after the TAVI. About the treatment and also the prognosis, about the patient profile and complication, patients tend to older with more comorbidity than the with post-surgical PVE. About 2/3 as high complication, acute kidney injury and heart failure are most frequent. About the mortality rate in hospital and 30 days mortality is high. It's the 16% to the 36%. And about 1 year mortality is higher. One is 41% to 59%. And the higher mortality associated with the higher patient risk. And very common is the staphylococcus aureus infection is the highest mortality. The treatment approach, we should use antimicrobial therapy similar to for the patient with prosthetic valve or endocarditis. And cardiac surgery is preferred for severe complications like prosthetic valve or heart failure. The surgery is underutilized, performed in just 20% of cases, likely due to age, old age, high surgical risk, and challenges in remove certain cardiac valve system. And about the endocarditis, after the transcatheter pulmonary valve implantation, and the incidence is a range from 1.6 to 4.0 per 100 patient years, and higher incidence compared to the surgical pulmonary valve intervention. About the valve type and risk, some studies suggest that the high risk with the bobbin jugular vein valve. So actually, we should not use the bobbin jugular vein. And recent last multi-center studies found no significant difference in IE rates between valve types. And about risk factor, the consistent factor associated with the increased IE's risk includes young age, previous history of IE, and higher valvular resident radius. About the prognosis and treatment, about the prosthetic valve stenosis, the numerous or severe stenosis occur in 1/3 to 1/2 the patient post TPVI, PV, and surgical valve replacement is performed in 26 to 56 of cases. Transcatheter therapy option includes valve intervention for severe prosthesis dispersion, either spot here endocarditis or urgent treatment with balloon dilatation. The valve intervention is also the difficult technique and very we used in this situation should be delayed at least 1 to 3 months following antibiotic treatment. So the antibiotic treatment is very important. We should always use before the valve intervention. About the mortality rate is to the IE episodes range from 0% to 11%, and the lower mortality compared to the TAVI patient, and likely due to younger age and less comorbidity TPVA population. About the infective endocarditis affect cardiac implantable electronic device. We will talk. We will listen to the next topic, and in this algorithm, as now we can see that it's a device to freeze no IE, possible IE, define IE, and we have some situation we have the CF extraction and CFG implantation. About the infective endocarditis in the patient admitted to intensive care unit. So it's the increased ICU admission in the patient with the IE. And the last second retrospective studies show a growing number of ICU admissions for the IE. And critical complication is rising due to the septic shock, acute heart failure, cardiogenic shock, and leading to the multi-organ failure. It's also the complication is very severe to the patient. And the healthcare associated IE rise in the healthcare associated rise in IRP in IE, and primary is staphylococcus aureus, and predominant effect to the older patient with multiple comorbidity, and urgent multidisciplinary care So in the patient with the IE patient require ICU should urgently discuss with the endocarditis team. And about the causative microorganism in infective endocarditis, respond for 56% of IE cases with high rates of complication and mortality. And other pathogens is the Staphylococcus, Enterococcus, and Gram-negative bacilli candidate. And the diagnosis consideration, we should identify the infective microorganism is crucial for effective therapies. And about the surgical therapy is to improve early and late outcome. And the challenge in the new patient.
Sorry, Dr. Tian, we lost your voice.
Independent predictor, male gender, increased surgery duration, renal dysfunction, heart failure, or peri-operate platelet count lower, and advanced support for ECMO in some occasional requests. And we should concern with the endocarditis team. About the right side infective endocarditis, about the prevalence is the cause for approximately 5 to 10%. And frequency may be increased due to the rising risk factor in some region. And risk factor is patient with congenital heart disease, patient with implantable electric device, the patient with who inject the drugs, and the causative microorganism is the Staphylococcus aureus is the common. And the one involvement is the tricuspid one is more commonly compared to the pulmonary ones. And about the clinical nature is the right side, IE is more benign compared to left side. Surgical is reserved in the patient, not a response to medical therapy. And the prognosis in the patient with the right side, when the patient with the CS relates right side, IE have a worse prognosis. And in the patient with immunocompromised patient, particularly in the fungal infection, is more poor, very poor prognosis. About the common causative organism is the Staphylococcus, especially in the patient with who inject drugs. And the coagulase negative Staphylococcus is more common. And methicillin-resistant Staphylococcus aureus, especially in the patient who inject the drug. And we when we didn't have a blood culture, we can use empirical antimicrobial therapy. It depends on the suspected organism, type of drugs, and so on, used by the person who inject drugs and infection location. And we should cover includes Staphylococcus aureus. And we can more option. We can have more option. For example, medicillin-resistant penicillin, vancomycin, or daptomycin, depend on the methicillin-resistant Staphylococcus aureus prevalent in combination with the gentamicin. And here's the recommendation according to the ESC 2023 about the surgical treatment for the right side endocarditis. About the infective endocarditis during the pregnancy, the maternal and fetal outcome, the maternal mortality is 18%. The preterm birth is 55.7%. Fetal mortality is high, 26%, and postpartum recurrent infective complication up to 27%. And the management is cardiac surgery under the cardiopulmonary bypass might pose a risk to the fetus. So in clinical, we should avoid this procedure. And the urgent surgical should not be delayed when indicated despite the risk about the infective endocarditis in the immunocompromised in patients. So in the solid organ transplantation, so the incidence and demographic is the incidence is 1 to 2 among solid organ transplant recipient, and solid organ transplantation with IE are typical in young and high prevalence in comorbidity, particular renal and liver disease. The common transplanted organ in the IE case is the highest in the kidney is 72%, liver is 17%, and pancreas is 8%. The IE characteristic in the solid organ transplantation patient is aortic and mitral IE are more common, with the right side being uncommon. And the mural IE is the more frequent in the solid organ transplantation patient. About the microorganism and causal, in hospital and healthcare related IE and more frequent cause. The common microorganism is the Staphylococcus aureus is the 34%, Enterococcus 17%, and Streptococcus is the 11%. In the patient with the human immunodeficiency virus, the significant reduction of IE is done among the SIV patient. From the USA, the studies set up 148 to 112 cases. It decreased significantly. The patient with demographic and comorbidities, the patient has become older with a high rate of substance abuse and comorbidities, and increased prevalence of congenital heart disease, prior or van surgeries, CS infection, hemodynamics among SIV patient with IE. So the common microorganism is Staphylococcus and Streptococcus. And the incidence and context about in the patient with neutropenia. The neutropenia is common in patients with hematological malignancy and receive the chemotherapy. So the neutrophil is very important because and it's when the patient use some medicine, for example, oxycycline, ceftaroline, may exacerbate neutropenia. About the non-bacterial thrombotic endocarditis, the incidence is the low 1.1% to 1.6% based on the autopsy study. For example, so predisposition factor, for example, systemic lupus erythematosus, antiphospholipid syndrome, cancer, disseminate intravascular coagulation, and the pathologies in the cancer patient is increase the production of coagulase factor and cytokine, high tissue factor expression. The underlying cause treatment address the root cause set at the systemic lupus erythemia. Anticoagulation therapy should be used with low molecule weight heparin, vitamin K antagonist, or unfractionated heparin. The surgical consider intervention with severe valve dysfunction or large fracturation. About the infective endocarditis and malignancy, the prevalence is about in the Japan core study is 70.6, and in the Eros endo registry is 11.6%. Patient characteristics are gender, older, and high frequency of non-cosmonial IE and procedure prior to IE, for example, non-dental procedure, intravenous catheter insertion, invasive endoscopic procedure, and genitourinary procedures, and a higher mortality rates in patients with the malignancy. And independent predict of mortalities, for example, elevated creatinine, congestive heart failure, lack of cardiovascular risk were indicated. So I also would like to conclusions about my topic. There's a diverse manifestation, the very varying clinical presentation across the patient group. For example, elderly, pregnant women, immunocompromised. And about the pathogen, variation is steep in common pathogens, for example, increased methicillin-resistant Staphylococcus aureus, and unique pathogens in a specific population, for example, fungal infection in immunocompromised patient. The clinical implication is important for a tailored diagnosis and a treatment approach, and impact of analyzed condition, for example, malignant congenital IC. About the future direction, we should continue research on emerging trend and treatment outcome, and need to comprehensive management strategy to address the complexity of II in non-rheumatic valvular heart disease. Thank you very much for your attention.
Thank you very much. An excellent lecture, and I think that you have covered so many subsets of patients in the non-rheumatic IE. I think when we are waiting for the question from the floor, I would like to ask, because from the ESC guideline on infective endocarditis, there's a new like a paradigm on the outpatient treatment, outpatient antibiotic treatment after the intravenous antibiotic in the hospital. Did you use that or experience that in your practice, and what's your opinion about that?
Yeah, yes. So thank you very much for your interesting question. So as you know that because in the patient with IEs, we should use the antibiotics very long time, especially in some circumstances. For example, patient with CIED device using drugs, the patient with the malignance. So the time for the using the antibiotics, for example, 1 month, or for example, and in some case, maybe we can extend to 6 to 8 weeks, for example. And so at the time, maybe when the patient after the time of using the antibiotic by the intravenous, I think it's the most effective way for treatment the patient with the IE. But I think in some case that we can use antibiotic after the patient has the treatment in hospital, and when patient in our hospital, it means the patient with should continues using the antibiotic for the extend the time of using antibiotic and cover that's to prevent about the recurrent of IE in the future. But in our clinic, our hospital, I think almost the patient they treat the IEs antibiotic, at especially the time when they are in hospital, because at that time we should take care, we should follow up very carefully for preventing about the complication. And it means that in some especially cases we can use our hospital antibiotic, but I think the more effective ways is in hospital antibiotic by intravenous. Yeah, thank you.
Thank you. I agree with you. I think that the way to use the outpatient is in the patient who is not immunocompromised, and it's very straightforward and has the certain criteria to be able to treat as an outpatient. So I'm looking for the question from the floor. I think feel free to ask or type in the question Q&A. I think that this is a very good opportunity to ask any questions that you may have. if there's no question at this time, I think I would like to introduce the next speaker, who is going to talk about the infective endocarditis in CIED or cardiac implanted electronic device, advanced in cardiac imaging diagnosis and curative. Speakers Dr. Monpraveen Amprai from Sirirat Hospital, Bangkok, Thailand. Dr. Monpraveen, please.
สวัสดีค่ะ Hello from Thailand. Can you see my slide?
Yes.
Okay. Today, I am Monpraveen Amprai. I would like to talk about the infective endocarditis in cardiac implanted electronic devices in terms of advance in cardiac imaging diagnosis and curative therapy. So for the cardiac device infection, these are the pictures from my colleague, Dr. Shriyapon. All of this patient has CIED infection. And this is the lead that explanted from the patient. Thank you for the Associated Professor Arisara for this case. So first, I would like to talk about the definition of the cardiac device infection or CIED infection. There is two types. The first is the localized infections, divided into superficial incisional infection, like in this picture, that the patient has the acute infection without the involvement of the pocket or the hardware. Another is the isolated pocket infections, like this picture, that the patient has limited to the hardware in the pocket that has the infection. Another is the systemic CIED infection, that the patient has got the systemic infection with or without the pocket infection, or in some case that is with or without the visible obstruction on the tricuspid valve or pulmonic valve or the pacing leads. And another is the cardiovascular implanted electronic device related IE. It is from the ESC guideline that it is equal to CIED infection with the clinical sign of the pocket infection and or imaging finding, such as the lead vegetations, positive FDG PET-CT on the generators or the lead, which fulfill the criteria for the valvular IE that everyone knows that has the major and the minor criteria as this. And in the patient who suspected the CIED associated IE, the first we have to do the baseline assessment and initial classification, such as we look for the clinical presentation of the IE, take the blood culture from the patient, and undergo to the TTE and the TEE. And then we have to think about the diagnostic criteria for IE in the patient. If the patient has definite, we can undergo to treat as the IE. But in some case that the possible for IE, we have to repeat the blood cultures if that is negative or doubtful. Or in some case, we have to repeat the TTE or TEE within 5 to 7 days. And another imaging, we can use the PET-CT to detect the pocket infection, or we can use the CT to see the pulmonary embolism that is the complication from the IE. And for the pathophysiology and microbiology, cardiovascular implanted electronic device-related IE has two mechanisms. The first is the local infection, and another is seeding via the bacteremia. And the factor for this is from the host, the device, and the microorganism. And for the microorganism, the first one is the coagulase negative staphylococci. And the next is the oxacillin sensitive Staphylococcus aureus. And then is the oxacillin resistant Staphylococcus aureus. And for the clinical laboratory advance in pathogen detection, also we have to do the blood and device specimen for the routine microbiological study. And another that can help enhance the device culture sensitivity is a vortexing sonication technique from the extracted CIED that can help improve the recovery of the pathogen but the limitation is it is not available in all clinical settings. And the role for inflammatory markers in the diagnosis of CIED infection, that is some study for the procalcitonin, it may be useful in diagnosis, and it can help to differentiate the local or pocket site versus the systemic infection. But another that it is not clinically reliable, such as the peripheral leukocyte count or the erythrocyte sedimentation rate, that is not used. And for the diagnosis and management, first I will talk about the pocket infection. The pocket infection for the pre-extraction state, we can see the patient with the device erosion through the skin or some purulent discharge from the pocket or some fluctuation or sinus tract with or without the positive blood culture. Or another, we can use the FDG PET-CT that with the abnormal activity at the pocket or on the generator side. And for the post-extraction state, we can see the intraoperative finding which consistent with infections such as the purulent discharge within the generator or pocket site or some inflammation, or another from the fluid culture or from the PCR sequencing or something like metagenomic generation sequencing with consistent with infection. And another is the lead or the valvular infection. For the pre-extraction, we can diagnose with 2 or more positive blood culture from Staph aureus or some species of the coagulase negative staphylococci, and the positive finding from the TEE with the echo density at the device lead or some vegetation on the heart valve. Or another, we can use the FDG PET-CT also that has abnormal heterogeneous activity along the leads or the prosthetic heart valve. And some in the post-extraction, we can see the positive device tissue or fluid culture positive or the positive for PCR or some sequencing. And the patient who's suspicious of CIED-related IE, we do the blood culture, TTE, TOE, or another such as the PET-CT, whether FDG PET-CT or white blood cell scan. And then we think about the diagnostic criteria for the IE. And if that is definite for IE, we have to use the antibiotic covering MRSA and the gram-negative bacteremia. And then we should do the definite CIED involvement. We can do the CIED extraction. And then we have to treat antibiotics. And then we have to reconsider again about the CIED reimplantation. And for the advanced in cardiac imaging for diagnosis, this is from the ESC guideline that recommended us. The first, we have to use the transthoracic echocardiography, and then transesophageal echocardiography. For the transesophageal echocardiography or transthoracic echo, we have to repeat it within 5 to 7 days if the clinical suspicion of CIED-related IE. And another in who TEE is not possible, we can use intracardiac echocardiography also. And another with the good sensitivity and specificity is the FDG PET-CT. And we can use the white blood cell SPECT-CT scan and chest X-ray and CT to evaluate the presence of the pulmonary complication from the IE. And this is from the JACC cardiovascular imaging, in depth of the imaging. The first, I will talk about the transthoracic echocardiography. We can use in both the patient with the CIED pocket infection or in case with CIED leads and valvular infection without the pocket infection. For the patient with suspected CIED pocket infection, we have to do the physical examination and take the blood culture. In the case with the positive or the negative with the receipt of the antibiotic before the culture, we should use the TTE and TEE again to think about the management. And when the case with the leads and valvular infection without the pocket infection, we have to take the blood culture. If that is positive, such as for the staph aureus or another case, we have to use the TTE and TEE also. And this is the case from outer faculty. This is a 34 years old male with the DCM set up for the ICD for the secondary prevention due to the DCM with the low LVEF. He presented with fever. As you can see in the picture, the pocket side is quite well, just mild erythema. And he has the positive MSSA bacteremia, and the TTE is as follows. This is the major format of the TTE that you can see. That is the AICD leads with the vegetation that very big. It is look like the grave. So this case, we think about the lead infection. And another imaging that is the transesophageal echocardiography. This is very important diagnostic tool for evaluating the patient with a valvular infection or who suspected that CIED infection. But as you know, there is limitation of the T because T cannot reliably distinguish between the infectious and the non-infectious lead-related echo density. So in some cases, they might lead to unnecessary device removal. In terms of the TEE, we can use in the suspected CIED generator pocket infection because it can use in the concomitant with the positive blood culture, or in some case that receive the antibiotic before the blood culture collection. And it helps to define the procedural remove strategy for the device. And another, we can define the shunt through the interatrial septum, define the valve of the tricuspid valve, and detect the pericardial effusion. And in case of the lead and the valvular infection without the generator or pocket infection, we can use the TEE with the FDT PET-CT to help increasing the diagnostic field of the systemic, such as the endovascular and intracardiac infection. This is our case again. He was undergoing to do the T. And the first picture is the deep transgastric 5-chamber explained at the AICD leads at the tricuspid valve area. As you can see, the large vegetation attached to the AICD leads. And the next is the explain of the mid-esophageal 4-chamber wheel. You can see the vegetation along the leads. And the biggest one is at the RA. And the next is the 3D of tricuspid valve at the RA wheel. You can see the vegetation that involves the tricuspid valve. And the next is the interatrial septum part that you can see the vegetation near the tricuspid valve. Thank you. The very beautiful picture from the Assistant Professor Silichai and Dr. Pontiera for this case. And another, I would talk about the FDT PET-CT. That is very good sensitivity and specificity. And it is useful in the setting of possible CIED-related IE in some case without the sign of pocket infection. But we have to interpret with caution in the recently implanted less than 6-week case. And some limitation that it can reduce sensitivity with a low-grade pocket infection, lead infection, and who receive antibiotic before the imaging. And this is the case from the Frontier Cardiovascular Medicine of the case with the pocket infection that you can see it is the increased uptake around the pocket without inside the heart. And another is the white blood cell SPECT CT. We can use it for the diagnosis of CIED infection, but it is limited availability in some hospitals. And this is the case that used. The first picture is the CT, and another is the SPECT1, and the last is the combined picture that you can see. The first is the some uptake at the pocket size, and the next picture that you can see the intracardiac portion of the lead that has uptake. And next, we can use the chest X-ray and the CT to help evaluate the pulmonary complication, such as this case. The case has the CT, but this you can see that is the bilateral extensive multifocal septic emboli with the capillary lesion, as well as you can see the bilateral pleural effusion without the evidence of the pocket infection. The pocket is beautiful. And for the management, such in our case, that is suspected the leads and the valve infection who has positive blood culture for the MSSA. So we have to treat as the CIED leads or valve infection. It is like in the patient who has CIED-related IE, we have to do the definite of the CIED extraction. So I will touch about the device extraction. We have to do the complete CIED removal. It is recommended in all patients with a confirmed infection of the leads because the conservative treatment is associated with increased mortality. But in some cases, with the large vegetations, it may be aspirated percutaneously before the lead extraction to reduce risk of the embolization of the vegetation. And percutaneous is rather than surgical extraction is the preferred posture. But we think about the surgical extraction, it should be considered in case of the large vegetation, such as more than 20 millimeters, or in some hospital that aspiration is not available or unsuccessful. And our case, when after the antibiotic treatment, the vegetation size is decreased. So thank you, Dr. Arisara. She has done the device extraction. And I will show you from the left side that we do the laser lead extraction. And the lead was extracted. And at the right part, this is successful AICD lead extraction. And in this case, the vegetation is resolved after the antibiotic. Thank you, Dr. Arisara, for this case. And the patient was out of hospital with the successful treatment. And for the recommendation, antibiotic prophylaxis covering staph aureus is recommended in the case with the CIED implantation. And in case we suspect the CIED-related IE, we have to do the TTE and the TEE. And the recommendation of the complete system extraction without delay with the initial empirical antibiotic therapy is recommended. And for the prevention, there is many risk factors for CIED infection. We divided into the modifiable and non-modifiable. The modifiable is the patient-related factor, procedural and device-related factor, such as fever prior to implantation, skin disorder, heparin bridging, oral anticoagulant. It is for the patient-related factor. And for the procedural-related factors, such as prolonged procedure that can increase risk of infection, hematoma, prior procedure, inexperienced implanter, temporarily passing while that increase the risk of infection. Another is the device-related, such as the abdominal pocket. Another is the non-modifiable, such as the patient with the ESRD, steroid use, renal failure, history of device infection, COPD, heart failure, malignancy, and DM. And for the postural-related factors, such as the lead repositioning, device replacement, and upgrade. And for the device-related factor, such as the CRT or ICD, like outpatient, more than 2 leads, abandoned leads, dual chamber device, and presence of epicardial. This is a non-modifiable risk factor that increase the CIED infection. So we have to reassess the indication of the primary implantation or the reoperation before to do. And we can reduce the risk by taking action on the modifiable risk factor, such as postpone the procedure if the fever or patient has got the infection, or we can treat any comorbidity or OAC uninterrupted or we have to do in the experience center, limited number of person in operation rooms such as. And this is the very heart of the central illustration. This is the very important picture. We have to do the prevention and the diagnosis and then the management. Thank you.
Thank you very much, Dr. Monpraveen, for the comprehensive lecture on the CIED infection. While we wait for the question from the audience, I have one question. When you have many leads, like when you have the CRT in the patient with heart failure, and then you have the IE, do you have to remove all the leads, or would you selectively remove only the lead involved? What are you going to do?
Oh, thank you for the very good question. I think in the recommendation they recommend about the complete lead removal because in the case that we suspect that CIED related IE, in some leads that has the infection, we cannot see the vegetation. So just we think about the vegetation. If that is in some lead without the vegetation, we cannot conclude that it is not related with the eye. So I recommend to remove all the leads.
Is there any question from the audience?
Yes, I would like to ask one question to Dr. Monpraveen. That in some case, for example, the patient has a long ties of CS implantation, so it's not easy to extract, even though we use laser or any instrument, but we cannot extract the lead and completely see it. So, as a case, what should we do?
In the case we cannot do the complete lead extraction, the use of prolonged antibiotics can be help us with this case, as I experienced with Dr. Arisara. Yes.
Yes, and when the time between the time you extract the CF, so when the patient has a severe, for example, bradycardia, so should you use a temporary pacemaker at the time you extract the effective device?
Yes, in some case that the patient need to use the pacemaker, we have to use the temporary pacemaker, or in some case they use like the permanent to another permanent that use like the temporary pacemaker before we do the lead extraction in some case.
Yeah, thank you.
And how about the PET scan for detecting the pocket infection? I think that is there any precaution about the time? Because I mean that immediately after you implant the pacemaker generator, you will have some inflammation. Will there be any caution about the using the PET scan earlier, or I think you don't think that's not the important question about using PET? So do you have to wait how many days after the generator implantation, or can you use the PET to diagnose the pocket infection, maybe that early on?
For the use of the PET scan, they recommended to use in the case with more than 6 weeks of the implantation. But if we use in earlier than the 6 weeks, we have to use another picture modality such as the TTE or TOE, or in some case with the clinical setting. because in the case that we suspect that the pocket infection, there is some clinical that can tell us. So I think in the case is after the implantation, more than 6 weeks, it is help us to use because it is will increase the sensitivity and specificity for the infection. Yes.
Thank you very much. And if there is no question from the audience, I would like to introduce our speaker, Dr. Olfi Lelia from Indonesia. She's going to talk about the infective endocarditis in adult congenital heart disease, diagnosis, pathogens, and management. Please.
Hello. Good
Yes.
afternoon, everyone.
Yes. We can hear you quite well.
Okay, I would like to share my slide. Okay. Hello. Today I would like to present about the infective endocarditis in adult with congenital heart disease, especially about the diagnosis and pathogens, and also the management. So, as we know that any patient with congenital heart disease has risk of infected endocarditis, especially whether it's unrepaired palliative or corrected congenital heart disease. And it causes most morbidity and mortality among patients with congenital heart disease. And the incidence of endocarditis in adult with congenital heart disease is about 13.8 in 100,000 patients in 1 year. And most of these patients have higher risk of IE, which is 100 times higher risk. And it associated mortality with has decreased to 10% because we have improvements of diagnostic of endocarditis, the treatments and the surgery, and also the therapeutic intervention. So our missions, because this is of special populations of endocarditis, so we have to increase the survival of patient with adult congenital heart disease. So we have to improve our diagnostics, the medications, and also the intervention, whether it's surgical or non-surgical intervention. So in our center, which is a single center that in National Cardiovascular Center Harapan Kita, Jakarta, Indonesia, in the last 5 years, we found about 174 from all 564 endocarditis patients, but the congenital heart disease is about 30%. And the adult congenital heart disease, it consists about 11%. Most of the blood culture results is gram-negative bacteria, and the most common congenital lesions that we found is 68% is patient with ventricular septal defect, followed by atrial septal defect and patent ductus arteriosus, and others there's a few with tetralogy of Fallot. And the locations of endocarditis in adult of congenital heart disease, it affects mostly in aortic and mitral valve, which is in the left-sided, especially with previous valve interventions. So in one of the journals stated that most of patients with congenital heart disease, it affected to the aortic valves. It consists about 56%. So it's very hard in the left-sided heart for congenital heart disease. So the diagnosis of infective endocarditis, it's mostly the same with other infective endocarditis that we found in native valve disease or other underlying infective endocarditis. So it's all followed with fever, malaise, shortness of breath, cough, chest pain. And we also have to search thoroughly from the history, whether they have dental procedure or they have a potential source of bacteremia. And the cardiac examinations also the same. It's mostly the same because it depends on the heart abnormalities that we found during the disease. So the populations of congenital heart disease is very challenging and it's very spatial because sometimes they include the prosthetic valve involvement, especially in patients with atrial septal defect or ventricular septal defect. And sometimes it involves the native valve involvement. And so also patients with congenital heart disease are prone to be likely to have arrhythmia, especially after the surgery. Some of the patients experience total AF block, so they have to get a pacemaker. So the risk of cardiac electronic implantation device related infective endocarditis is also high, especially and also patients with post congenital heart disease intervention and surgery. So this is very special because it's related to other part of the cause of infective endocarditis. So the diagnostic criteria it's the same. So we heard before that Dr. Cordero stated that they are modified dukes and also the definitions of 2023 ESG have modified diagnostic criteria of infective endocarditis, and we still follow this criteria to develop diagnostic in adult with congenital heart disease. And this is the same. We take from the European Heart Journal in 2003, whether to build whether it's definite, possibly, or rejected infective endocarditis based on the native, prosthetic, and implantation of a device. And the microbial diagnosis, usually it's positive. Blood culture is the cornerstone of the diagnosis. So we took also the 3 sets of blood culture, which is detect 96 to 98% of bacteremia. But about 10% of the patients actually shows negative blood cultures, whether the antibiotics were given before the test, or the slow-growing pathogens, or it's whether the non-bacterial thrombotic endocarditis. So actually the serology testing and PCR testing can help identify the specific pathogens in this case. So we move to imaging. Absolutely, echocardiography is the first line imaging used to diagnose infective endocarditis. Simple tools that we usually use is transthoracic echocardiography. But when we want to see any complications such as perivalvular complications, small vegetations, or prosthetic valve endocarditis, or even the vegetations associated with implantation device, we also try to use a transesophageal echocardiography, which is it's recommended if the result of transthoracic echocardiography is inconclusive. Moreover, such as like Dr. Jen Wei Chen previously mentioned that MRI and CT also benefits for diagnosing the infective endocarditis. So we totally agree that this technique will help us to diagnose this infective endocarditis, especially in patients with complex anatomy structures in adult congenital heart disease. So the pathogens, so the blood cultures were less often positive in adult congenital heart disease. So most of pathogens in congenital heart disease, we found it's Streptococcus viridans and then Staphylococcus species, followed by Enterococcus species. So one of the journal state, one study, they found mostly these pathogens involved in adult congenital heart disease. And most infective endocarditis cases in adult congenital heart disease is community acquired and followed with nosocomial and other infections. So this is how we look whether the risk factors is high or intermediate. So in patient with congenital heart disease, not including isolated congenital valve abnormalities, it's including high-risk patients. And these patients are very prone to have infective endocarditis. So the prevention is really necessary for these patients. So the risk factors leads to antibiotics prophylaxis, which is recommended in patients with untreated cyanotic congenital heart disease. And any odontogenic infections or dental procedures are also risk factors, especially in patients with congenital heart disease. And we also agreed that before, the pathogens found in patients with congenital heart disease, mostly Streptococcus viridans, and this also commonly found in patients with dental procedure. So the management of this patient with congenital heart disease is, since the principles of symptoms, complications, and the basis of diagnosis is not differ from any infective endocarditis in general, so it make it the management will be for the antibiotics will not very differ, but for the diagnostic will make it difficult because it's complex anatomy and the presence of artificial material. What it means, because if we have patients with a new valve, the new septums, heart septums, or patients with Fontan, patient with Rastelli. So they have artificial materials that put into their body. So the detections of those materials, the vegetations, will be difficult. And this is challenging for us. So we have to use many methods to manage to diagnosis and also to manage the patients. So the successful treatments, it's relies on antimicrobial therapy, which is bactericidal regimens are more effective. And mostly it's important that we have to decide whether these patients have to do surgery, because by removing infected material, it will help the patients to recover more truly to the cause of the vegetations. So the indications of surgery, first, it's for the heart failure due to regurgitations of the valve, or patient with uncontrolled of complex infections, a very big vegetations, or patients with embolisms to prevent embolisms in, especially in pulmonary or in the brain. So in a study in 2023, 80% of adults with congenital heart disease patients underwent surgical treatment for infective endocarditis. And it has high percentage of severe complications such as abscess, pseudoaneurysms, fistula, valve perforations, and severe regurgitation. So, but not only surgery, but it combined the surgery and also the antimicrobial therapy. So patients with adult with congenital heart disease is we did more surgery frequently, more than non-congenital heart disease groups. So this is our post-operative complications we found in adult with congenital heart disease. So they involve with multi-organ involvements and complex procedures. This is very challenging in post-operative patients. And most of frequent complication consists of coagulopathy, re-explorations of the thorax, hemodialysis, strokes, low cardiac output syndromes, respiratory complications, prolonged hospital stay, and sometimes the patient need a permanent pacemaker. So last but not least, we have to improve the preventions because patients with adult with congenital heart disease is very prone to infections. So antibiotic prophylaxis is recommended for patients with high risk characteristics, which is we found in patients with congenital heart disease. So these patients include those with previous IE, patient with prosthetic valves, whether it's biological, mechanical, surgical, or transcatheter, patient within 6 months of placements of prosthetic materials, patients with residual intracardiac shunts at the sites of or adjacent to previous repair with prosthetic materials or devices. And last, patient with uncorrected cyanotic heart disease. So based on ESG, so it's recommended in any dental extraction for antibiotic prophylaxis. So I think we still need a patient with adult congenital heart disease to have any antibiotic prophylaxis for any interventions in other interventions. So in patient with congenital heart disease, so we have to be aware. We have to prevent and diagnose early, and also treat the vegetations or the infection very early, because patients is a higher rate to have infective endocarditis, and the signs, and sometimes even though they have similar symptoms, we have to be aware, yeah, and then we have to prevent all the risk factors. We have to avoid any factors that may make the patients will get the infective endocarditis, and we have to make early diagnosis. So if we make early diagnosis, so we can make early treatment for the patients with congenital heart disease. So this is the patients in our hospital, 18 years old patients, women patients with patent ductus arteriosus. So we can see that aligned with pulmonary trunk, there's a multiple vegetations along the main pulmonary trunk with the PDA. And then the second case, it's a man with 26 years old with post-PSD closure. 2 years after the PSD closure, the patient has residual severe aortic regurgitations, and it make a big vegetations in aortic valve 2 years later. This is the upper echocardiography, the upper image is at 2022, and the bottom image is 1 year later. And then this is patient with tetralogy of Fallot, 20 years old man. Unfortunately, the patient has low ejection fractions of left and right heart functions. So we cannot do surgery. This is a challenge because sometimes patients with congenital heart disease comes in the late phase with the low ejection fractions and have a high pulmonary hypertension. So it's very hard to correct the heart because it's very late to, they come late to our hospital, but they have this vegetations in the heart. So it's very challenging to treat these patients. And the last patient is patient with Epstein anomaly, a 22 years old man. This is, you can see that, the patient has small vegetations around around tricuspid valve. And he was planned to do the surgery after, but the patient didn't came after we planned the surgery. So in conclusions, any patient with congenital heart disease has risk of infective endocarditis, whether it's unrepaired, palliative, or corrected. And diagnosis of IE in congenital heart disease, the symptoms are similar to other lying heart conditions, and the most common pathogens responsible for IE in adult with congenital heart disease is Streptococcus viridans, Staphylococcus species, and Enterococcus species. So the antibiotics prophylaxis is recommended for patients with high-risk characteristics, especially in patients with adult congenital heart disease. And surgery contributes by removing the vegetations and corrections of the heart. And preventions of IE is important in patients with adult with congenital heart disease. Thank you very much. If there are any questions, I would love to answer the questions. Thank you.
Thank you very much for a very comprehensive lecture on the IE in congenital heart disease. If I understand correctly, on your, your earlier slides, you mentioned that in your institution, the pathogen that causes IE in this group of patients is gram-negative. Is that right?
Yes.
And why is that? Because it's always mentioned that usually it's the strep or the staph is gram-positive.
Yes.
Is there any reason for that challenging explanation for the gram-negative predominant? I think that's very interesting.
Yes. In our institutions, there's a lot of in Asia, it's very difficult to detect the pathogens actually. So if we see that probably most patients has many infections, and sometimes it's negative, sometimes it's positive, but our community, it's not a very clean environment actually in Indonesia. Probably it's because if I read a lot of study, they stated that in most of Western country, the pathogens will be different, but that's what we found in our hospital. But probably that will be changed again. It depends on what kind of pathogens that we had in our country. So fortunately, we have that results. That's the retrospective data that we discovered within the 2000s, in the last 3 years, I think. But before that, I would like to know about 5 years before in our hospital. But it's very difficult because our data before 2020, it's not. There's some problems because we changed it from the old manual medical record to e-medical record. So yeah, probably that's will influence the results, but that's what we found within the last 3 years.
Thank you very much. I see that Professor Lin has joined us again. I think
Hello,
that he's with
Professor.
us all along. Dr. Lin, do you have any question or any comments on the what have we gone so far?
No, I am today. I'm just listening to the all the lectures because you are special in this field. But I do know that the infective endocarditis nowadays is getting more and more complex, not getting easier. Because we are treating a lot of patients with good results, and these patients are surviving longer, we have more and more problems to come out. Take those patients with CIED, or those patients with adult congenital heart disease. It's really quite a new area for us to face with.
Yes,
I
can I
couldn't
have one
agree more.
question?
Yeah. Yes.
Yes.
Of course.
Yes. One of the issue is about the tooth extractions before heart surgery. One of the surgeons stated that they don't need to do the tooth surgery before heart surgery, but if I think that if it's in high risk patients, I think it's still necessary to do the tooth extractions before surgery. What do you think about that, Professor Lin?
It's quite dangerous procedure, really. Any patient D is always a dangerous procedure. And now we can have more laser guided extraction. Maybe it's better, but it's not always applicable to congenital heart disease surgery. It's even more difficult. Sometimes you cannot even assess the location. That's the problem. Maybe our surgeon, they can tell us more about this. Professor Su, any comment on it?
For the CIED infection, if the lead can be extracted percutaneous, maybe the patient requires the open surgery. I think the open surgery is quite easy for the surgeon, but the patient always do not want to do the surgery. But for the surgical removal is indicated for a difficult case. Yeah.
Yeah, thank you.
For all the speakers, is there any comments or any question or would like to have additional comments for that? We have a little time before we close this webinar. Dr. Su, you have any comments or any additional remarks for this session?
As a cardiac surgeon, this is a very good opportunity to listen to all the new things about the infective endocarditis, especially for the diagnosis and the pathogen and everything. It's a great experience. Thank you.
Thank you very much. First, Lin, I think that we are reaching the time that we have to close this webinar. I also have learned a lot from this, and I think that we all agree that we are facing the changing pictures of infective endocarditis, whether it's a native valve, rheumatic, non-rheumatic, or prosthetic, the CIED, or IE in congenital heart disease. I would like to thank all speakers, my co-chair, Dr. Su, and I would like to give a big hands and would like to invite all to join me in giving the big hands for Professor Lin, who is the program director, and also his team for hosting this webinar. Thank you very much, Professor.
Thank you.
Thank you.
All. Thank you all for your great contribution to this webinar. Thank you all. Thank you.
Thank you. So I would like to close this webinar and thank you all, the audience, and all who participate in this very interesting event.
Okay, we
Thank
will take a photo If everyone can open your camera, we can have it together. Yeah. Okay. Thank you all. Thank you. Okay. We will close the section. Thank you for all the contribution from all of you. Thank you all. Bye-bye.
Thank you very much.
Okay.
Bye bye.
Yes.
Bye-bye.
Bye-bye. Okay.